Thank you very much for inviting Homebase and for inviting me to speak. And I can do this, okay, great. So I could have focused on different things. We developed many innovations in the treatment of veterans and novel treatments for PTSD. But for today's talk, I'm going to focus on a powerful but underutilized treatment or modality for post-traumatic stress disorder, which is hypnosis. And I'm going to demystify it a little bit for you. I'm going to explain what it does and what it can do for PTSD. Hopefully I will, within 15 minutes, I will do a broad overview and some techniques that could be really helpful. And hopefully I would incite you to be interested in those of you who are clinicians, whether you do CBT or other treatment modalities, to get to learn it and practice it. All right, so what is hypnosis, first of all? Hypnosis is one of the oldest mind-body treatments known to Western medicine. It was popularized in the 1800s. We know the word mesmerized, meaning entranced, because Franz Mesmer had some specific ideas and used hypnosis. Then Jean-Martin Charcot, in the 1860s in Paris, La Salpêtrière, used hypnosis to treat conversion disorder. So it's been around for a long time. It's been used for treatment of conversion reactions, for medicationless anesthesia in India, for wound healing, and others. What is clinical hypnosis? Because hypnosis has a double reputation. Stage hypnosis is very well known, so people ask, are you going to make me cluck like a chicken? So what is clinical hypnosis? Clinical hypnosis is a treatment between a clinician and a patient, so abides by all the principles that are subsumed by the medical specialty. It's practiced within a therapeutic relationship. I have to say here that there are quite a few mind-body methods, so meditation, mindfulness, EMDR, others all use some kind of variants of a state of trance. But here you have a dyadic relationship where the hypnotist and the patient work together and guide the patient to a hypnotic state of trance, which is a natural phenomenon. So I usually explain this to patients that they've already experienced trance multiple times, like when you drive a car and you're thinking of something, and all of a sudden you say, did I pass my exit or did I not? Meanwhile, someone was driving, someone didn't crash. So this is a natural state of trance. Here, trance is used because in trance, people are actually more resourceful and can achieve things that they cannot achieve outside of trance. So, in the state of trance, the hypnotherapist and the patient influence body processes that are not usually thought to be under voluntary control, to downregulate the patient's emotional reactivity, which is, I'll tell you, is very important in PTSD, and to alter trauma-related maladaptive beliefs. That is, if I can advance it. Let me see. Yeah. So, specifically, why hypnosis for PTSD? In PTSD, one of the most troubling aspects is that the patients have the feeling that things are happening outside of their will and awareness. Their bodies react in their own way. They have flashbacks, they have nightmares, they jump, and they don't feel in control, and they feel disempowered. Here, hypnosis has a lot to offer. So in hypnosis, there's a change to a calmer state from which the patient can actually more resourcefully approach PTSD symptoms. A typical induction includes going to a beautiful place on a gorgeous day and involves physical relaxation. This allows the patient to decrease their body reactions that are on high drive. Second, the natural dissociation component of hypnosis. There's dissociation as someone enters into trance. There's the focusing of attention, usually inward, could be outward, but inward, and not paying so much attention to external happenings. So this can help separate the physiological reactions of the patient upon trauma reminders, the rapidly beating heart, the sweating, sometimes shaking, from the psychological associations upon trauma reminders, and allows the patient from a more calm body state to approach the trauma reminders. Patients, when they're calm, can absorb rational and non-reactive cognitive self-statements that influence their reactions. And therefore, all of these different aspects of hypnotic work can bring the patient to re-experience a sense of control, re-empowerment, and positive expectancies for the treatment outcome. Okay, so an example, I'm going to focus here more on the negative feelings and dissociation and moral injury, but an example of treating flashbacks, which is cluster B, PTSD symptoms, flashbacks, nightmares, is the split screen technique. So, oops, I'm so sorry. Can someone help me restore it? Who's looking for the laser pointer? I will promise not to touch it again. Okay. The split screen technique, which was described by Herbert and David Spiegel, father and son at Stanford, in which first the patient is asked to go into trance. Then imagine a screen, and the screen could be a TV screen, could be a movie screen, could be a blue sky, and project all of their experiences onto the screen, including their trauma experiences. Projecting these experiences outside of oneself, rather than experiencing them from like a first person, seeing them through your own eyes, feeling them within yourself, makes it a little bit less impactful. That's right. Also by using hypnotic sensory techniques. So once I've projected my memories and visualization onto a screen, I could change the distance from the screen, I could change the color to black and white, I could change the speed, and that influences the strength of the experience of these memories. Second, after the patient has gotten some ability to do that with the screen, they're asked to split the screen into left and right. And on the left-hand side, they're asked to project all the most troubling aspects of the trauma. Whereas on the right, they're asked to project the things that they've done. Since they're sitting in front of you, this means that they've survived. To have survived, they usually have done something to help themselves survive or help others survive. So on the right-hand side, they are asked to project the things that they've done that have helped them or others survive. So this begins a process in which the patient, instead of seeing themselves as a victim and the whole experience is a one bad event where they were totally powerless, they begin to see that they actually did some things that helped them survive. So moving to this cluster D PTSD symptoms, that is the symptoms, the dissociation, negative beliefs about oneself and others, and negative feelings. The negative feelings that people commonly experience after trauma are fear, horror, anger, guilt, or shame. Negative emotions can be addressed directly by eliciting competing positive emotions, or could be addressed indirectly by changing negative self-beliefs and correcting them. So one example of addressing these negative feelings directly is the GLAD technique, or the grateful, learning, accepted or achieved, and delighted, popularized by Altman. So while the patient is in trance, the therapist suggests, in this moment, you can experience being grateful, learning, accepted or achieved, and delighted, and then suggest that the patient focus on the feeling of delight, vivifying it and deepening its experience. An example from a colleague and co-author of mine, Kaloyan Tanev, is that a patient who had been violently raped experienced in trance a trip to Paris with her husband, revivified the sensory experience. Like she saw the red checkered tablecloth, the lace curtain, smelled the coffee, tasted the sweet pastry, et cetera, et cetera. And she was directed to maintain the positive affect state that was elicited in the imagery. Whether you use the screen technique, screen projection technique, or other techniques, guiding the patient to face the reality of the trauma, because many times people deny parts of the trauma or forget parts of the trauma and cannot move forward. So guiding the patient to face the reality of the trauma while feeling safe, bear it, grieve their losses, and realize that they were able to do things to help them survive, allows them to give themselves credit that they did things to survive, and also to help them change their self-image from a victim to a survivor. Self-hypnosis is something we frequently teach patients, so we demonstrate and we guide people through trance, and then frequently we make a recording and send it to the patient and say, practice this daily or twice a day, because this is a skill that you learn and you could do it yourself. Hypnosis and trance is not something that we do to the patient. We're like a guide, so everyone has experienced trance of some kind. We guide the patient how to enter trance, how to exit trance, how to control affect during trance, and how to do work in trance. So teaching them how to control their affect, usually negative affect, patients get more of a sense of control over the present. And here again, we could teach them technique that they could change the images that they have regarding their self-worth. And hypnotically, they can change them, and they could change the feeling. This could be felt experientially. It's not a cognitive experience. It's an experience that they participate in that's very powerful. CBT, cognitive behavioral therapy, and one of its members, cognitive therapy, is a very much evidence-based therapy for PTSD, first-line therapy for PTSD. The cognitive therapy teaches the patient to identify automatic thoughts. They could be conscious, but many times they're not conscious. They require some digging to identify. And then subject them, test them as treatable hypotheses. And then if they're exaggerated, for example, people frequently say harm is just around the corner, or the world is an unsafe place. The only place where I'm safe is at home. If I leave home, I'm likely to be assaulted or hit by a car or something else. So cognitive therapy treats these as testable hypotheses, and they usually use the possibility and probability. So I had a patient who was a police officer who was hit by a car while on duty, and he developed this belief that if he left home, he would likely be hit by another car. And so I asked, so what do you think is the percent probability that you'll be hit by a car? And he said, 50%. So I said, okay, so you've been out how many times in the past week? He said, 10. So you were hit 5 times by a car? And he said, no. So this is cognitive therapy. In hypnosis, anything that could be done while the person is alert and awake could be done in trance as well. So here, Milton Erickson, a legendary psychiatrist and hypnotherapist, believed that people have all the internal resources necessary to heal and make changes. Stephen Gilligan, following that tradition, guides the patient in trance and helps them identify a limiting truth or belief, then talk to the part of the injured self with comforting words, such as, I am whole and precious and untarnished. The therapist then guides the patient to connect to the part of self that is unwounded. For example, I'm unwounded and unwoundable. I'm whole and I'm unbroken. And then the patient is encouraged to focus on the feelings of ease and calm that these reassuring words and positive self-affirmations elicit. Over time, this reinforces a new sense of self. Excuse me. Moral injury, that's been addressed so far, but just to review. The psychiatrist Jonathan Shea coined the term moral injury for experiences where someone who holds legitimate authority has betrayed what is morally right in a high-stakes situation. Brett Litz, more recently, defined it as perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. Following that, these experiences lead to cognitive dissonance with internal attributions of blame to oneself, experience of shame, guilt, or anxiety, and withdrawal from others. And over time, these lead to isolation, suicidal thoughts, self-handicapping behaviors, and suicide. In terms of treatment, some of the treatments for cognitive therapy actually may not be appropriate or may not work here, because cognitive therapy identifies beliefs that are exaggerated. Like this belief, the only place that's safe for me is at home. But in some of these cases, the beliefs may not be exaggerated. They may be based in reality and the experiences. So trying to change them may not work. So what both emphasize here is a therapy which involves the community, listening non-judgmentally to the person, accepting, understanding the person, and the person feeling accepted, engaging in taking full responsibility for whatever they did, and then thinking about how their life now and in the future would be meaningful, what the actions going forward are going to be. In terms of hypnosis, here's some examples of guilt and shame and how to deal with them. So survivor guilt can be addressed in trance by having the patient meet with the injured or deceased person, say in trance what they wanted to say at the time but didn't, and listen to the response of the person. Because this is not just a cognitive exercise, but an actual experience in trance, it brings relief much of the time, whereas talking about it and thinking about it did not. Shame can be addressed by the parts model, first suggested by Watkins and Watkins. In trance, the therapist elicits the patient's loving part, which reassures the shame part. And a variation of that is creating a group of people who the patient may know or may know about, who possess the experience, compassion, and hopefulness and love that they need. And they could be friends, relatives, historical figures, etc. In cases of complex PTSD, usually means trauma that has happened repeatedly, trauma that has happened in childhood, which is present in a good proportion of people who join the military who have had unsettling childhoods with lots of trauma. The ideal parent figure protocol developed by Dan Brown, who passed away a couple years ago, but was a very prominent Harvard psychologist in the Boston area. The patient is asked to imagine an ideal, not their real parent, because the real parent usually has had problems, ideal parent figure who possesses, knows exactly what to say and how to say it, and comfort the patient. So the therapist asked the patient to imagine this ideal parent in any sensory modality. They could hear him, see him, touch him or her, etc. And this quote is worth reading because I think it's very eloquent. Every patient will initially or eventually create personalized imagery of parent figures behaving in ways that promote secure attachment. When the attachment system present in every person, regardless of how deactivated it might be, meaning regardless of how badly a person was abused, is activated by the therapeutic frame and the ideal parental figure method, positive attachment imagery emerges spontaneously from the innate sense of what is needed for the development of healthy, secure attachment. So a little bit about combining hypnosis and RCBT, cognitive behavioral therapy approaches. So, as I said, the CBT is known as the treatment of first choice. There's lots of evidence for it. There is evidence that hypnosis can enhance the power or the effectiveness of CBT. One meta-analysis showed that 70% or more patients who received cognitive behavioral hypnotherapy had greater improvement than those who received CBT alone. It's underutilized, but it could be powerful. The other thing is that after traumatic events, people spontaneously, as a way of defending themselves against the trauma of the situation, experience spontaneous dissociation, which could be protective initially. But there's also evidence that if that dissociation continues for a long time, that's predictive of the development of PTSD 6 to 12 months later. PTSD approaches the same with the same. It uses dissociation where people can access these memories and states, but teaches the patient how to regulate affect and how to control the dissociation. And it becomes not scary, but manageable and a tool for treatment. Okay. As I said, the cognitive work that can be done when the patient is fully alert can be done also when the patient is in trance. And because the patient is taught how to regulate affect and feel safe, ego defenses are relaxed compared to the alert state. Dissociated memory and subconscious beliefs can become accessible, processed, and reframed much faster than when the patient is alert. And one last thing here, the vivifying concepts is something very typical of the use of hypnosis. So a concept such as I can be overpowered, but I can bounce back, and overall I'm able to influence myself and people around me in a good way, could be vivified by an image or an experience of a willow tree that is bent by strong winds but bounces back once the winds subside. So this is very typical and really increases the impact of these cognitive self-affirmations. So conclusions in this very brief presentation. Hypnosis is a state-based treatment. So it changes states and uses that as a base for any intervention. It can move people with PTSD into a state of calm, downregulate their emotional reactivity, and we know that one of the models, psychophysiological models of PTSD is upregulated. The sympathetic nervous system is upregulated, and the parasympathetic nervous system is downregulated. Many biological treatments, etc., to correct that. PTSD is one way to downregulate the physiological overactivity. There is evidence that supports the use of hypnosis in PTSD and to support the use of hypnosis in addition to CBT. And we encourage the use of hypnotic techniques by any practitioner who deals with PTSD. As an aside here, so these are some materials that if you'd like to check, you can. I just published a hypnotic techniques for PTSD article. I really wanted to publish it in a CBT journal because I thought this would be especially good for my CBT colleagues who do not practice PTSD. I submitted to 3 journals and I got the same response, which was, we appreciate your submission at an editorial. They did not submit it for peer review. They said, but we don't think that this will be of interest to our readers. So I said, okay, so I'm not gonna be hitting my head against the wall continuously. Submitted it. It was published in the American Journal of Clinical Hypnosis, but with a little regret because I thought this would really be meant for people who do CBT, not hypnosis. So I hope that I've interested you to know more, and I'm happy to take questions if there's time. If there isn't time, you could contact me. But I hope that elicited some interest in you towards hypnosis.